Hello, everybody. My name is Milind Desai, and I am a cardiologist and vice chair of Heart Vascular Thoracic Institute at the Cleveland Clinic in Cleveland, Ohio. It is my pleasure to invite everybody to join in this wonderful podcast, where I will be joined also by my colleague and good friend, Dr. Shinya Unai.
Hi, my name is Shinya Unai. I'm one of the staff surgeons at the Cleveland Clinic. I'm the surgical director of the Aortic Valve Center.
And today we are going to talk about a very interesting topic, radiation-associated cardiovascular disease.
So, Dr. Desai, when we get a referral for radiation, a patient that had a radiation, how would you approach these patients?
Thanks. So these are some of the most challenging patients we see in pretty much all of cardiovascular medicine. These patients, first and foremost, we have to think about these patients given their past medical history. So if you had mantle radiation or massive radiation to the chest years ago, all these patients could potentially have radiation-associated cardiovascular disease features. The biggest problem is often under-recognition, misdiagnosis, and incomplete workup where people do not connect all the dots. So that's why it is important to have a broad look at these patients, certainly at an experienced center. Often, in cardiovascular medicine, we play the game of incidence and prevalence. We try to understand. Let me tell you, over the years, a lot of data has been published in that context, and in my opinion, a lot of it is inaccurate with its own institutional biases. So when a patient is referred to us with a suspected history of radiation heart disease, we look at every patient on his or her individual merit. We do extensive not only clinical evaluation, but multimodality evaluation. So obviously a thorough history and physical of what the radiation was, where the radiation was, check out the tattoos related to the radiation, try and get the amount of radiation they got. Are there any additional risk factors that could aggravate radiation heart disease? And we do multimodality imaging, so a thorough echo, which often reveals peculiar features that we've learned over the years that are associated with radiation heart disease, including multiple valves that could be affected. You could have thickening of the area between the aortic and mitral valve, aortomitral curtain. You could have heart dysfunction or a stiff heart. Pretty much everybody should and does get a CAT scan to look at the lungs for traction bronchiectasis or fibrosis or radiation damage. We also look at calcification known as porcelain aorta or massive calcification of the aorta because that is often seen. Then we also look at basically coronary anatomy because these patients often also have very aggressive, very proximal coronary artery disease. Each and every patient, we, at least as baseline, look at their lung function studies, including diffusion capacity, which looks whether or not the lungs are restricted. Depending upon where the radiation could have extended, we may also need to look at the carotid arteries. Why is this important? Because radiation heart disease is what I would classically call pancarditis. So if you got radiated in your chest, anything and everything that comes in the way of the radiation beam is fair game for potential damage. And the damage is mostly due to fibrosis or scar tissue. So skin, bones, lung lining, lungs, aorta, pericardium, coronary artery disease, valves, electrical system, carotids, thyroid gland, esophagus, anything and everything. So we have to think and plan for all those things. Mm-hmm. Beyond the basic imaging, we would then, in a lot of cases, we would also look at cardiac MRI to look for features of restriction or constrictive pericarditis. My threshold for doing a right and a left heart catheterization is very, very low in these patients. I typically do not rely on stress testing because of a high rate of ostial proximal disease and a high rate of false negatives. So you will see me order left heart catheterization and a right heart catheterization with invasive hemodynamics very often in these patients. So in general, once we clinically evaluate, once we do these multimodality imaging evaluation, I see the patients back typically the same day, the next day, and synthesize the data and basically figure out what the next steps are, which in very often, many cases, is this patient needs advanced therapeutic interventions, which is when I often call you, Dr. Unai. So once I have worked these patients up, I figured out they have advanced radiation heart disease and they're symptomatic because of that. I punt them off to you. What goes through in your mind as you are referred a patient with radiation heart disease?
Yeah, so thanks, Dr. Desai, for the thorough explanation of the issues surrounding radiation heart disease. So patients that come to us for surgery can have a wide variety of cardiac issues, and coronary disease that require bypass surgery, valve disease, typically the aortic valve and the mitral valve. They're fibrotic and calcified, and they can be leaky or stenotic, but typically they cannot be repaired and may need a replacement. These valves can be heavily calcified. Not only the valve, but the surrounding tissue can be calcified as well and may require extensive decalcification. And the tissue in between the aortic valve and the mitral valve can be calcified as well. And reconstructing that tissue, commonly referred to as the commando procedure, may be required to place an adequately sized valve. And the aorta can also be heavily calcified, referred to as a porcine aorta, and this may need a replacement also. And to replace this aorta, we may need to cool down the body temperature to protect the vital organs and the brain and stop the circulation for a while to replace the aorta, similar to what we do for aortic dissection surgery. And the sac surrounding the heart, called the pericardium, can also be fibrotic and calcified from radiation and leading to restriction. In these cases, rather than the traditionally performed pericardiectomy, which only removes part of the pericardium, the anterior part of the pericardium, we perform what we call a radical pericardectomy that removes the entire pericardium, including not only the anterior part of the pericardium, but the inferior and the posterior pericardium, to completely remove the sac surrounding the heart, to remove the constriction completely. And most patients with history of radiation will have some degree of fibrosis and restriction of the heart muscle as well, and which can lead to slow recovery from the bypass machine, and may spend some time in the intensive care unit. And in some situation, these patients may require a mechanical support, either with an intra-aortic balloon pump or with an Impella, a pump that goes into the heart directly to assist, may be required. And to further complicate the situation, radiation can affect the nearby lungs and may have some degree of impaired function as well. And for very few patients that have severe restriction and dysfunction of the heart, transplantation may be the only option, and either just a heart or a heart-lung transplantation. And successful outcome for these complex radiation heart disease patients requires an experienced anesthesiologist, a cardiac surgical team, and an intensive care unit that are comfortable managing all these complex issues.
So let me ask you a question. Say the patient presents to us and we decide, heart surgery is a complicated affair in these patients. Say the patient only has one valve that is diseased, or just one or two coronary arteries that is diseased. How do we approach this as a team?
So since these patients are at increased risk with heart surgery, we typically try to avoid heart surgery as much as possible. So when we see these patients, we discuss as a group with a experienced cardiologist that is experienced in radiation, a cardiac surgeon, and an interventional cardiologist, and look at the anatomy and figure out what can be treated with a catheter and what cannot be treated with a catheter and may require open heart surgery.
Yeah. So I think what Dr. Unai is suggesting is we have to learn from our past experiences, and at the Cleveland Clinic, we've learned a lot about this disease from our past experiences. So in our prior publications, we have shown that open heart surgery in these patients is riskier than the average patient, but in carefully selected patients, the outcomes are very, very good. One of the words of caution that we've learned over the years is we know that reoperation in this group tends to be a much higher risk proposition. So at least as a team, what we are trying to do is avoid a reoperation. In the case of radiation heart disease, our goal is to fix everything that needs to be fixed in one setting and avoid multiple reoperations. So we definitely try to minimize the urge to go and fix a single valve or just a one vessel CABG, a one vessel bypass, etc. We wait for disease to progress. So in waiting for the disease to progress, if we have to do a catheter-based intervention in the interim, that's what we often end up doing. And again, the data on outcomes is, radiation heart disease patients have to be treated with kid gloves, with extra care, because the outcomes in patients that are not well managed, the outcomes can be bad. So that's where experience, a team discussion, everything comes into play. So in the post-op setting, Dr. Unai, what are the things do we watch out for in terms of recovery? How do you manage patients and families' expectations?
So when I see patients with radiation, when I talk about heart surgery, the risk of the operation, it is not uncommon to see these patients that would, if not for radiation, would be out of the ICU intensive care unit in 2-3 days. However, with the restriction and fibrosis of the heart, it may take a little while for the heart to recover completely, and it's not uncommon that the patients will require inotropic support for a few days, even if the systolic function, the squeezing of the heart, is normal. And in addition, because the radiation may affect the lung function as well, the separation from the ventilator may take a little more time than usual. And in addition, because of the lymphatic dysfunction from the radiation, it is not uncommon that these patients need develop fluid around the lung, requiring thoracentesis or a small catheter in the pleural space to remove the fluids. So in general, I typically say at least a few days up to a week in the ICU, and the hospital stay can be up to 2-3 weeks, even if best case scenario.
So I think this is important to recognize, because often, yes, you're absolutely right. So as I am working patients up early on, I'm doing a lot of stuff managing families' expectation, because a lot of these patients come from out of town, often from many states away. So their stay in the hospital and in the surrounding area after their discharge is a little prolonged. And often it is important to recognize every fluid buildup in and around the lungs in the post-op setting is not due to heart failure. A lot of it is due to lymph drainage, and just pounding patients with diuretics may or may not be the best strategy. So I think some of these things are absolutely important to recognize and to manage expectations. What else should we be? Yes, an important comment actually I wanted to make is, in our experience, transplantation is one potential option, but what we have seen over the years is a lot of times we reserve that as the absolute last option, because a lot of these patients, they've had prior malignancies, and with transplant, what ends up happening is you immunosuppress them, you give them immunosuppressants, and some other cancer emerges. So we try our best to take care of these patients through standard surgical things. But it is also important to recognize that this disease can be predictable. So you need to start screening these patients at an appropriate time so that you don't get to an advanced stage, or you plan for a procedure well before they get to an advanced stage. I think that is important. The other important thing, at least I hope that by the time my career winds down, a lot of these patients will no longer, this disease will no longer exist, because there's a lot of new technology that is evolving in radiation oncology, where they use better sources of radiation, they radiate less, and they protect the heart and the vital organs in a much better fashion than what was happening 20, 25 years ago. So I think the best option in these patients would be, as they say, prevention is better than cure. Any last words, Dr. Unai, in these patients?
I think we covered a lot, and but I think the most important message is that patients with radiation heart disease, we have to have a plan for the next 20 to 30 years. Again, we try to emphasize the importance that we don't want to do multiple heart surgery. We want to plan for one heart surgery at the right timing. And before that, we try to discuss as a group, as a team, how to avoid a second heart surgery. How can we delay the first heart surgery with percutaneous options? And I think the team discussion is very important. And at the Cleveland Clinic, I think we have a great team of interventional cardiologists and cardiac surgeon and intensive care to manage these patients that could be highly complex.
This disease truly represents a team effort, and presence of an highly experienced team at a highly experienced center is absolutely important in excellent outcomes. It's the surgeon, the imager, the clinical cardiologist, the interventional cardiologist, but not only that, the ICU support staff, the anesthesiologist, the post-op nursing floors. Everybody works in sync to take care of these patients, so that we are not reinventing the wheel every time a patient like this is seen. So thank you again for joining. Hope you found this useful.
Thank you.